Good evening, everyone. A very warm welcome to today's international speaker program on precision oncology in genitourinary malignancy. We are delighted to have all of you join us for this important and insightful academic session. To begin this proceeding, it is my privilege to invite Dr. Niti Krishna Raizada ma'am, who is the Principal Director and Head of Department Medical Oncology and Hemato-Oncology, Fortis Hospital, Bangalore. To kindly deliver the opening remarks, Dr. Raizada is a distinguished leader in the field of oncology with immense contributions to cancer care research and education.
So, good evening to one and all. A very good morning to you, Dr. Neeraj. Sincerely, thank you for participating today in this. And I mean, we are really privileged and honored to have you. I thank each one of the participants to be here today. We are discussing a very relevant topic, relevant across the globe, because it's one of the most common malignancies globally. And of course, emerging issue in India as well, because until now, the data available for us wasn't as great. But we see in our routine practice that genitourinary malignancies are becoming actually one of the top malignancies which we deal with on a regular basis. When we look at the global dynamics, genitourinary malignancies, including prostate, kidney, bladder, and of course, even testis, are major health concerns. Testis being one of the most, probably a very promising malignancy in terms of results with more than 95% survival. But prostate cancer, again, if you look at the total dynamics, we have about 1.4 million cases diagnosed annually. Especially in our country, we see a lot of advanced prostate cancer, which is a cause of concern. A lot has changed when we deal with these cancers. They are treated differently because of different biologies, different genetic profiling, and different therapeutic response. And now we individualize each patient, and which is what is the focus of our today's talk. We need nuances, we need newer clinical approaches and personalized care. What has changed, as I said, is personalized therapy, real-time monitoring systems, and of course, integration of artificial intelligence, shaping immunotherapy, and of course, targeted therapy approaches. We have multi-omics analysis, which is integrated by either NGS, that is next generation sequencing, single cell omics platform, and of course, the landmark studies, one of the important one in genitourinary malignancy is TCGA pan-geo analysis, which has actually led a lot of, enlightened us of the way forward. And for this very important topic, precision oncology in advanced prostate cancer, we have one of the global leaders in prostate cancer management, Dr. Neeraj Agarwal, who is Professor of Medicine, a Senior Director of Clinical Research from Huntsman Cancer Institute. He is Presidentially Endowed Chair of Cancer Research. He is Director of Center of Investigational Therapeutics, Director of Geo-Oncology Program at Huntsman Cancer Institute. And he'll be delivering this talk on precision oncology. This is followed by a talk on precision oncology in bladder cancer by Dr. Shilpa Gupta from Cleveland Clinic. She'll be joining us shortly. And then, of course, there's a very short panel discussion in which Dr. Jehan Dabar from Fortis Hospital, Mumbai, will be talking about a case. And then Dr. Nagendra Sharma, medical oncologist from Max Delhi, will be talking about another case on geomalignancy. So our first session starts with Dr. Neeraj. Over to you, Dr. Neeraj.
Thank you, Dr. Niti. Let me pull up my slides. You can see my slides, right?
Yes, sir.
Okay, thank you very much. First of all, thank you for the opportunity to Dr. Raizada and the team. It's such a pleasure to be here. So I'll be talking about metastatic prostate cancer and how precision oncology has evolved very rapidly. And it's finally so nice to see prostate cancer being treated with precision oncology approaches. But this is just a start. And we will be seeing many other precision therapy or precision or targeted therapy being approved in prostate cancer in the near future. Regarding the conflict of interest, I do not have any personal conflict of interest with any pharma since May 2021. My institution do receive research funding for several clinical trials, and they are mentioned here. This is my lifetime conflict of interest. So this is a snapshot of targeted therapies, approaches which are already approved or being tested in clinical trials in metastatic prostate cancer. And if you can see, starting from the nucleus, we have, or if you look at the DNA, we have obviously AR. AR is the #1 target in prostate cancer because it is a main driver of disease progression. But beyond AR, DNA repair pathways, PARP inhibitors have been approved now in post-chemo setting, pre-chemotherapy setting, and first-line mCRPC setting. But beyond that, there are several other which are being tested, and I'll be talking about them. If you look at this picture above the cell membrane, we are witnessing a new era of targeted therapies which are targeting the cell surface receptors. So I use PSMA as an example. Here we can see lutetium PSMA, which is Pluvicto, is already approved, is a radioligand therapy. But then we are also seeing trials of T-cell engagers and PSMA targeting antibody drug conjugates being developed. And this is just one cell surface receptor. There are many others which are being targeted. So as I said, we are seeing an unprecedented era of targeted therapies being either tested or being approved in prostate cancer. So I'll be talking about these classes of drugs. I'll spend more time on PARP inhibitors and pembrolizumab and lutetium relative to other ones which are being tested. Let's start with the PARP inhibitors first. We know in 2016, Dr. Pritchard and team published for the first time, although there were data before, but this is the paper which really brought role of PARP inhibitors or potential for PARP inhibitors to be tested in prostate cancer to my attention. And this study showed that 11% of prostate cancer patients, or metastatic prostate cancer patients rather, they had germline mutations in when they had metastatic prostate cancer. And then we looked at more than 3,000 patients with who had tissue NGS testing in the real world setting. And this is the paper from JCO Precision Oncology. And again, a substantial number of patients had targetable mutations at the time. So let's talk about the PARP inhibitor monotherapy first. So we have olaparib and rucaparib approved in the US. You know the data. We know the data for the olaparib trial. We started the trial in 2015 or 16. And then the results were reported in 2019. And it was the first PARP inhibitor to show overall survival benefit after failure of ARPIs or androgen receptor pathway inhibitors in metastatic prostate cancer. And the survival was improved by about 4 months. If we look at rucaparib, the Triton-2 trial, it showed improved rPFS or PFS by about 4 months. And we have not seen OS data yet. And then that brings me to the combination therapy. The rationale for combining PARP inhibitor and ARPI is here. What is the rationale? The way I explain to my patients that when we hit the prostate cancer cells with androgen receptor inhibitors, the PARP comes to the rescue of cancer cells. When we inhibit PARP or poly-ADP ribose polymerase, that leads to decreased AR function. So there seems to be a synergy between the AR and PARP inhibition. And we have summarized all the preclinical data in this European Journal of Cancer paper. So feel free to download this. This is free access. And this can show us, it has compiled pretty much a lot of preclinical data from the providing the rationale for combining these two drugs. And the 4 trials which were started in this setting, and then last one, the Caspar, was not completed. And we have 3 trials which have reported results in this setting, the Propel, Magnitude, and TALAPRO-2 trial. These are more recent data, so I'm spending a little bit more time on these. So this is the overall design of these 3 trials. And then these are the results of these 3 trials. And I will just focus on TALAPRO-2 trial for the sake of time and for this discussion. But just to summarize, Propel trial showed improved PFS in patients regardless of HRR positive or negative status. Obviously, benefit was more pronounced in patients who had HRR mutations, which are present. BRCA1 and 2 positive patients derived the maximum benefit. In the TALAPRO-2 trial, we see very similar results, enzalutamide plus talazoparib versus enzalutamide. And enzalutamide is a very active control. As we can see, the median PFS in this control arm in all-comer patients was like 19 months, which is what we expect from enzalutamide in the first-line mCRPC setting. Patients who had HRR mutations, the median PFS was about 13 to 14 months. It tells us that enzalutamide alone is not a good drug for patients, or ARPI alone, they don't do that well in patients with HRR mutations. And here are the overall survival results. So TALAPRO-2 trial showed overall survival to be positive. So in all-comer patient population, it was 9-month improved. In patients who had HRR mutations, there was a 14-month improvement in overall survival. Now, if you recall, we have not had a single drug which is approved in a metastatic CRPC setting, which has exceeded 6 months of overall survival benefit. So these data are quite striking regarding overall survival of this combination compared to an active control in patients who had HRR mutations. There was a 40% reduction in risk of death by adding talazoparib to enzalutamide. With that, I think NGS testing is a must now in metastatic prostate cancer patients. And we really hope that these trials will also, these combinations will also show benefit in hormone-sensitive settings. So TALAPRO-3 trial has completed accrual. We just saw the results of the Amplitude trial being presented in the ASCO 2026 and 2025 annual meeting. And EvoPAR Prostate 1 trial is ongoing. So this is the Amplitude trial design, which was presented by Dr. Gert Attard. We started enrolling in this trial about 4 or 5 years ago, and it was very heartening to see the trial reporting positive results. And this is the snapshot of Amplitude trial, just for the sake of completeness. Patients who had HRR mutations, they were randomized to abiraterone plus niraparib versus abiraterone only. And radiographic progression-free survival by investigator review was the primary endpoint. And strikingly, if you look at the baseline demographics, 90% of patients had de novo disease, 80% of these patients had high volume disease. Only 16% of these patients received docetaxel chemotherapy in the hormone-sensitive setting, which was allowed by the trial. And that tells me that enthusiasm for using docetaxel upfront is pretty low, and patients may not like docetaxel upfront, at least in these centers where the trial was open, including our center. And if you look at the results, the trial met the primary endpoint of increased radiographic progression-free survival in patients with BRCA1 and BRCA2 mutations and all HRR mutations. All subgroups seem to be benefiting, regardless of whether they had visceral metastasis, they received prior docetaxel chemotherapy in the hormone-sensitive setting. So they received up to 6 cycles of docetaxel, and they were randomized to ADT plus abiraterone plus minus niraparib. And with that, secondary endpoints such as time to symptomatic progression were also favorable to the niraparib arm. Overall survival results are immature for now. These are the subgroup analysis. Please note that it is very hard to dissect the survival outcomes in each one of the gene subsets. We never do that for any other trial, for any other therapies. It is almost impossible to do a trial which is powered for all of these subgroups. BRCA1 and BRCA2 were the most dominating mutations, and there was clear benefit. But again, as I said, we have seen from the other analysis, especially the one from the FDA analysis in the castration-resistant setting, that many other gene subsets seem to derive benefit from ARPI plus PARP inhibitor combination. If you look at the safety profile, there were no new safety signals. Hypertension is something which is easy to control, and PARP inhibitor-associated anemia, which really happens at the grade 3 level in up to 50% patients, which can occur up to 50% patients. We don't decrease the dose upfront. We start everyone at the full dose and decrease the dose in only those patients who are developing grade 3 anemia. But in this case, niraparib is more well tolerated from the anemia perspective, and we didn't see any new toxicities. With that, there are new trials which are coming up, TALAPRO 3. Hopefully, we'll see the results in the near future. And the EvoPAR Prostate 1, saruparib, is being added to ARPI in the hormone-sensitive setting. Now, let me move to the lutetium PSMS 617, also known as Pluvicto. Everybody knows here how Pluvicto works, again, targeting the PSMA on the cell surface. And lutetium 177 is the beta particle, which is tagged to this small molecule, which binds with the PSMA. So it's a small molecule, which is a carrier, is called as PSMS 617. Lutetium 177 is the radioligand or radioactive beta particle, and it basically causes DNA damage once it is delivered inside the cancer cells. This is the comparison between the VISION trial data and the PSMA-4 trial data. VISION trial showed an OS benefit of 4 months. In the PSMA-4 trial, where Pluvicto was used by itself, not combined with the ARPI, it was compared with ARPI switch. And we can see there was a pre-specified, if you look at the pre-specified PFS benefit, is about 3.6 months. But then 2 post-hoc analysis showed that PFS seemed to improve to up to 6 months. Overall survival was not positive, likely because of a substantial number of patients crossing over to from the control arm to the experimental arm. And we also saw the results from the SPLASH trial. So if you compare the SPLASH trial, which is very similar, lutetium 177 is the common therapy between these two agents, but the carrier is different. Here, the carrier is PSMA INT, and we see very similar, actually, results from the SPLASH trial, as we saw with the PSMA-4 trial. So we look forward to approval of this PSMA INT-based lutetium 177 in the near future. Now, I will briefly touch upon pembrolizumab because it is so well tolerated. And in those patients who have MSI high, TMB high prostate cancer, it seemed to have durable benefit, even though we don't have a randomized trial. So this was the original approval of pembrolizumab based on the basket trial, where there were a small number of patients with prostate cancer who seemed to derive benefit with pembrolizumab when they had high TMB. And we just looked at the real-world data set. Hopefully, the paper will be published soon. Nicholas Saig is one of my postdoc fellows. And we looked at patients who had MSI high prostate cancer. We looked at patients who had TMB high prostate cancer. And we also looked at those patients who had TMB high but not MSI high prostate cancer. These are relatively small number of patients, but please note that, as Dr. Raizada just mentioned, this is a high tumor burden in the society, millions of cases across the world. So even 1, 2, 3, 4% can be a lot of patients across the world. And that's why I always test my patients for MSI high, TMB high status, because pembrolizumab is a very well-tolerated therapy, and most patients seem to derive durable responses with pembrolizumab. Now, coming to other pathways, and I'll be brief regarding the discussion of these pathways. We know there is a crosstalk between AKT pathway and the AR pathway. And based on that, this Capiva Certi plus abiraterone, also known as Capitilo 281 trial, was designed in the metastatic hormone-sensitive prostate cancer. So these patients had PTEN loss by immunohistochemistry. And radiographic progression-free survival is the primary endpoint. We saw the press release on like last year that patients who had PTEN deficient metastatic hormone-sensitive prostate cancer, they achieved a statistically significant and clinically meaningful improvement in radiographic progression-free survival. We hope to see the results in the very near future. And if the trial is really positive, obviously I have no reason to believe it is not going to be positive. It may mean that checking or testing for PTEN deficiency by immunohistochemistry may become standard of care for patients with metastatic prostate cancer. Now let's come to antibody-drug conjugates. As I discuss with my patients, antibody-drug conjugates are a smarter way to deliver chemotherapy. These are essentially chemotherapy drugs, which are delivered in a more targeted fashion. So this is a picture which is created by one of my fellows, Zeynep Oze. And we can see here that there are several ways to deliver these chemotherapies into the cancer cells. You can use the receptors present on the cancer cells, and I'll show you the name of the receptors in a moment. And there's another way is to allow linker to dissolve and release the chemotherapy in the microenvironment of the cancer cells. The microenvironment is usually acidic inside the cancer cells because there's hypoxia, the pH is low. So the linker is designed to dissolve or release the chemotherapy payload in the acidic atmosphere. So that way, the chemotherapy not only targets the cancer cells, but also those who are expressing receptors, but can also target those cancer cells which are not expressing those receptors. So I really like this novel way to deliver this chemotherapy, not only to the cancer cells, but also to the macroenvironment of the cancer, where other cells which don't express the receptors can be targeted. So this is a snapshot of antibody-drug conjugates targeting PSMA. And again, these are very early data. What really excited me was this last, if you look at the last column here, the drug which targets the B7H3. These patients had multiple lines of therapies, and these data were presented in ASCO 2025, so annual meeting of ASCO a few months ago. And these patients were heavily pretreated, and they seem to have definitely very promising objective responses and PSA responses. But definitely there are other ADCs which are being developed. I thought this was really exciting. The B7H3 targeting ADC, which is using the topoisomerase 1 payload. I look forward to seeing the data from the phase 3 trial, but definitely this is a new era for ADC, which has started in patients with metastatic hormone-sensitive and castration-resistant prostate cancer, metastatic prostate cancer. Now let's talk about the PROTACs. What are PROTACs? The way I define PROTAC to my patients is that they bind with the AR, regardless of whether AR has mutation or not, ligand binding mutation or not. And they basically grab the AR and put this in the garbage bin of prostate cancer, which is proteasome. So AR inhibitors, these AR degraders, I call them AR degraders. Right now, they are on earlier phases of development. There are some phase 3 trials which have already started. But the way I look at AR degraders, down the line, 4, 5, 6 years down the line, they will have the potential. I think they have the potential to replace the current ARPIs from the treatment of prostate cancer. It will take time, but it will likely happen, in my opinion. So these are the AR degraders which are in development. There are some phase 3 trials which have already started. And there is a theme here. We see that AR degraders seem to be more effective in patients who have this AR ligand binding mutation versus who do not have AR ligand binding mutation. And as I mentioned, it's too early for them to replace ARPIs, but I think the way progress is being made, they will challenge ARPIs down the line. So now coming to the T-cell engagers, I'm very close to finishing my talk. So T-cell engagers, what are T-cell engagers? The way I explain to my patients, T-cell engagers are bridge between T cells and the prostate cancer cells. We know prostate cancer cells are associated with immunosuppressive microenvironment. T cells are not able to engage with prostate cancer cells very well. So what T cell engagers do is that they just grab the T cells and bring them close to the prostate cancer cells and bind with them. And then T cells can start having direct effect on the prostate cancer cells. And this is one of the most exciting classes of drugs I'm seeing in the treatment of prostate cancer right now. So there are multiple T cell engagers which are being developed. The most exciting ones, in my opinion, are the xaluritamig, which is targeting STEAP1 on the prostate cancer. And then another one is KLK2, pasritamig. The data were presented in ASCO 2025. And the most appealing part of pasritamig was that literally there were no grade 2 CRS, only grade 1 CRS. So if we can handle this CRS part of T-cell engagers, they can potentially be delivered on an outpatient basis. And our patients will not have to come to the hospital and be admitted. And this improved efficacy and safety as well of T-cell engager may make them a nice, very effective companion therapy in patients with metastatic prostate cancer. So of course, these are being tested as monotherapies right now in phase 3 trials. But in my opinion, they will become the part of the multi-agent combination therapy in prostate cancer, where we'll be using ADCs or radioligand therapy with T-cell engagers, and we'll try to induce durable responses and treatment-free interval in patients with metastatic prostate cancer. So with that, last part is the CAR T cells. These are quite early in the development right now. We don't have a lot of mature data for CAR T cell therapies. The way I explain to my patients, CAR T cells are T cells with a GPS on their surface. And the GPS is programmed to look for prostate cancer cells. So we have a car with a GPS, especially we look at those auto-driving cars. You put the direction in the GPS and they basically go to the destination. And CAR T cells are designed to look for prostate cancer cells. So these are the data from the CAR T cells we have seen so far. And I remain excited about the CAR T cells because I think CAR T cells and T cell engagers are the two immunotherapy modalities which will have the potential to induce long-term responses and potentially cures in patients with metastatic prostate cancer. I would like to conclude by mentioning these data. Chadi is one of my fellows, and we looked at the next-gen sequencing in metastatic prostate cancer and urothelial cancer. And in prostate cancer, and Dr. Gupta will talk more about the urothelial cancer, less than 30% of patients had NGS testing in the US in 2022. And I think this is unacceptable because pembrolizumab has been approved since 2018. Olaparib has been approved since 2019. And we still have a very small number of patients undergoing NGS testing. And we need to do a better job on this one. So I'd like to conclude that this is the best time to be a GU oncologist in the era of prostate cancer medicine since 1946, when ADT was approved as a way to treat patients with prostate cancer. And we will continue to work on identifying new targets and biomarkers. Thank you very much. So this is my team. I'd like to acknowledge my team at Huntsman. Thank you.
Thanks so much, Dr. Neeraj. It was an absolutely wonderful presentation, very enlightening. And I have quick 2, 3 questions, if you allow me.
Yes.
And I know, you mentioned that subset analysis is generally not a part of trials, but any reason why Amplitude trial had less response in the PAL-B2 subset?
These are very small number of patients, and not every subset was stratified for high volume de novo status. So slight difference in de novo status or high volume status can always make a difference if these subgroups are so small. We know PALB2 predicts very good response to PARP inhibitors, not from one trial, but from multiple trials. So I'll continue to endorse ADT plus ARPI plus PARP inhibitor combination in patients with PALB2 mutation.
Right. So, and as far as lutetium therapy go, obviously the indications are moving uphill. From previously significantly treated people to now moving up the ladder. But have you seen any special safety concerns with extensive visceral mets or when the tumor burden is extensive?
I think all of these therapies will have the potential to cause more toxicities when we use them early on. So a patient who is supposed to live for 18 months, and if I take away their salivary gland function, or if the kidney function goes downhill, they have 18 months. It may not matter as much. But this same patient who is being treated in hormone sensitive setting, and they're expected to live for 7 to 8 years, to live that long with those toxicities way more disrupting on quality of life. So I always keep in mind when we use these medicines upfront that side effects do matter more and more.
Anything in terms of myelosuppression or liver toxicity which has been significant? Because actually, in our clinical practice, we have had quite a few patients, probably because of using lutetium therapy in later lines when the fitness is already compromised, where we have seen significant liver dysfunction, significant myelosuppression.
These are radiation therapies, and side effects apply to all of these drugs. Pembrolizumab, PARP inhibitors, AR inhibitors, they are associated with cardiovascular risk. Androgen deprivation therapy is associated with, I think we are seeing an era of increasing cardiovascular morbidity and mortality in patients with metastatic prostate cancer as they are living longer. The median survival has gone from 3 years to 2.5 years to 5 years. And all of us have patients who are in their 9 years and 10 years of living with metastatic prostate cancer. So obviously, all of these toxicities will continue to matter more. And I agree with you. I don't want to just talk about one drug here, radioligand therapy or radiation therapy. We know we give radiation therapy to the body. There are long-term risks associated with them. Similarly, radioligand therapy with lutetium-177, we give them after chemotherapy, after ARPI. They have anemia. They are living for 18 months, as I mentioned. It may not matter as much. But if you give them earlier and they exclude patients from subsequent chemotherapy, for example, or T-cell engager therapy, or CAR T-cell therapies, that matters to me. So I think same applies to other drugs. I think it will be ultimately the art of medicine. We all be using these drugs in a way they have not been tested. Docetaxel has never been tested after ARPI. Docetaxel was approved in 2004 when ARPI did not exist. We continue to use docetaxel after ARPI failure. I think similarly, we'll be using all these drugs down the line using our own art of medicines, if you will.
Actinium therapy, any thoughts?
Actinium is an alpha particle. It's a great question. I know we all know that alpha particles are different from beta particles. They deliver more radiation in a more focused fashion. They have less radiation given to the distant parts of the body. I think I'm really excited about alpha particles, which are using targets beyond PSMA. And there are trials which are happening, which are combining PSMA targeting beta particle with alpha particles, and overall new phase of radioligand therapies,
Yes.
which is ongoing.
Actually,
Oh,
yeah, Dr. Neeraj. Thanks so much. Actually, to a certain extent, it makes me happy that US is only doing 20% patients NGS. I mean, we are not that behind, I guess. I mean, at least we offer choice to most of our patient, and we have lovely support from pharmaceutical industry where, I mean, most of the patients are offered testing. Sometimes even free testings are offered to our patients, especially
yeah.
advanced post first line, advanced
Yeah. So
prostate
that
cancer post first line.
30% in 2022, I think it has gone up to 50% now. And this is across the population. This is
Right.
Flatiron database. So not our institution, it's everyone in the US. So if you look at all patients with metastatic prostate cancer, half of them are getting NGS testing right now, and we need to do better.
Right, right. Thanks so much, Dr. Neeraj. Really appreciate it.
Thank you very much.
We
Thank you,
have with
Neeraj.
us, we have Dr. Shilpa Gupta joining us. Thanks so much, Dr. Gupta, for, I was actually kind of worried whether you will be joining on time or not.
Yeah, no, I
But
was in another meeting, but yeah, I'm here. So
thanks so much. Really
So
appreciate it.
may I request something to Dr. Gupta? I have a hard stop in 22 minutes. So if you have time, if you can quickly discuss the prostate cancer case, and then stage
yeah,
will be
yeah,
all
yeah.
to Dr. Gupta. Is that okay,
That's fine.
Shilpa? Okay.
Yeah, yeah, yeah.
Okay. Is that okay?
Doctor, yeah,
Dr. Neeraj?
absolutely, sir. Absolutely, absolutely. We will take up the Dr. Dabar. Will you be able to take your case, please?
Yeah, sure. Hey, good evening, everyone. I'll just share my screen. Yeah, is my screen visible?
Yes.
Okay.
Yes.
So, it was a wonderful talk, Dr. Neeraj, and thank you so much for having me over. So, this is one of those cases where molecular profiling had really made a difference, and even in the end of the therapeutic journey. So this was a 65-year-old male, relatively young for prostate cancer in India. So in 2022, he had some lower urinary tract symptoms and was worked up for the same. And he had a fairly raised PSA. What I remember correctly, it was something around 900 to start off with in 2022. His PET-CT showed a primary prostate lesion and extensive bony mets. The patient was a known CKD with a baseline creat of around 2. He was non-oliguric, not dependent on dialysis. So a trust biopsy was done, which showed a Gleason score 8 adenocarcinoma prostate, and it was a metastatic disease to start with. So this was all in an outside center. He was started with ADT, with androgen deprivation therapy, and upfront surgical castration with enzalutamide, along with denosumab. And all of this went on for a good 1.5 years with good disease control. Subsequently, he had progressive disease. His PSA level started to go up and was then started on next line of docetaxel with a fairly good tolerance, and his disease progressed after 9 cycles of docetaxel. In the interim, for some reason, he was put on abiraterone, and as expected, it did not really work, and disease progressed on around 4 to 5 months on abiraterone. He was then started on the next line of Cabaz.
Dr. Dabar, what was the duration of treatment of docetaxel? 9 cycles is 27 months, right?
9 cycles every 21 days, sir, so around 7 to 8 months.
So that's 6 months, right?
9 every 21
Almost.
days, sir.
6 to 7 months, right?
7 months, yes, sir. 7 months.
So it's very similar to what we saw with abiraterone. It's not very different.
Yes.
Yeah.
So probably it was docetaxel effect also lingered on maybe. But so yes, so then he was then put on cabazitaxel, and post 4 cycles of cabazitaxel, he had disease progression, And he did not even tolerate cabazitaxel well. He had neutropenia, required admission once for IV antibiotics and febrile neutropenia at that time. And he was not a candidate for lutetium therapy because of his chronic kidney disease. So this is when he was referred to for only best supportive and palliative care and was admitted at our center just for supportive care. But at the insistence of the family, who were really keen to do something, we did a PSMA PET. His PSMA PET showed extensive bony mets and also liver lesions. So we got a fresh liver lesion biopsy, which showed adenocarcinoma of prostate primary, and we sent it for a CGP. And also to mention that he already had a germline BRCA done at his primary center, which was negative. So I would like to ask, so how would we approach this patient with a very driven family, with driven relatives who come with this kind of a patient? What would be our next step? If anybody could take it.
The patient has progressed on ADT plus enzalutamide upfront, then received docetaxel, then received abiraterone, then received cabazitaxel, and then received lutetium 177.
No, he did not receive lutetium. So because of the CKD, because of chronic kidney disease, he was not a candidate for lutetium therapy.
Yeah. So you are doing the right thing by doing the CGP testing of the tumor. For these patients, we usually offer them trials. There's not much which is approved. Radium is too late for this patient. And Sipuleucel T, we don't use much, also known as Provenge, which was tested when there were no ARPIs. So in the absence of a clinical trial, I agree with tissue and liquid biopsy and CGP.
So I think that's what we did. We got a fresh biopsy, sent it for the Guardant test, and this was what the report threw up. It was an AR amplification. He had an ARV7 alteration and an ERBB2 amplification, which was quite exciting. Along with that, his TMB was around 6.98, and this was a tissue profile. And he also had a KRAS and FGFR2 amplification. And if you look at the liquid profile, so again, the AR amplification was there, but he had a PSM C3IP BRCA fusion, a CDK12 deletion in exon 1, 2, and exon 9 to 14. Again, the ERBB2 amplification was there in the liquid as well. So this was the liquid plus solid CGP that I had sent. So based on these findings, what would be the next most appropriate step? And then I obviously in the subsequent slides, I will tell you what I did.
Yeah, so the patient seemed, so first of all, I'm glad you did the tissue and liquid biopsy both, because tissue, by the time prostate cancer patients have progressed on multiple lines of therapies, there's significant tumor heterogeneity. And if we do a biopsy of one spot, it can miss multiple mutations, which could be present in other sites of metastasis. So liquid biopsy really captures the overall genomic profile of the tumor better than a tissue biopsy. And we see here tumor mutational. So what is so you have CDK12 mutation, BRCA mutation, and then I see that there is a ERBB2 amplification. If we just look at the approved therapies for now, we can use olaparib for this patient.
Absolutely, sir. So, and also in the liquid, he had a TMB of 22. So I was not quite sure how well would immuno work with a TMB of 22. So I did not really act upon at that point of time. So as I discussed, we have the options of PARP inhibitors, we have the option of anti-HER2 and immunotherapy based on a TMB. So what I thought that this would be my best chance to probably offer him something, and he was still relatively well preserved. So I gave him a combination of NHER2 with one step down dose and with olaparib at just 150 mg BD, keeping in mind his creat clearance, which was around 37 at that point of time. And he so far had a decent tolerance with, a good biochemical response. His PSA has gone down from 600 to 340, and his recent PET is showing a partial metabolic response and is in relatively good health. So, what would be, I think, your take, Dr. Neeraj, or anybody in this esteemed panel? So, novel combination, I know.
Would we have thought of sequential therapy than combination?
Yes, I think that was a major debate in my mind also when I was thinking of what to offer him. But I wouldn't know if he would really make it to the next line of treatment as well. So I thought I wouldn't know what would work better. Is it olaparib or NHER2?
See, I'll be honest with you. After 4 or 5 lines of therapies, none of these drugs have any data. Even olaparib was approved after in patients who have been failed by a ARPI, and some of the patients had been failed by docetaxel chemotherapy. So 5 lines, really, there is no data out there. From that perspective, it is great to see the patient getting response. I think olaparib is pretty straightforward here with BRCA1 mutation and CDK12 mutation. I'm not sure about trastuzumab deruxtecan. I won't be able to use it here. It won't be reimbursed in the US because we don't have the label based on the NGS testing results. But I respect your decision, Dr. Dabar. And the most important part is patient is doing well. That's what matters.
And the main important thing is that sooner or later, when he progresses, what would we think of next? Best supportive care, or would you still consider immunotherapy based on that TMB?
Tumor mutation burden is high in the liquid biopsy.
Liquid.
So I will definitely use it. There's nothing to lose.
And on progression,
definitely an attractive therapy.
So would we combine probably an immuno with a PARP inhibitor, continue a PARP inhibitor, and add an immuno to it, or just discontinue the PARP as well and just single agent immunotherapy?
Yeah, I would again, as I said, there are no data out there to show, no randomized data for immunotherapy in this setting. I like to use only single agent monotherapy like pembrolizumab based on the evidence. Yeah. I think Dr. Gupta has to leave, so we can start.
Yes. Right. Thank you.
Oh, thank you.
Yeah.
Thank you. This was a very challenging case, and looks like you did everything you can for the patient. So thank you, Neeraj, for your great talk. I was able to attend most of it. And let me share my screen. And thanks to Dr. Joshi for the invitation. Okay. Can you see my screen?
Not yet.
Okay.
Yes.
Yes? Okay.
Yeah.
Let me make it slideshow. Oh, sorry. Format. Okay. So shall I start the talk? So we'll talk about precision oncology in bladder cancer. So I'm going to talk about the role of biomarkers, current state and future directions. I know a lot of this stuff is also being done in India, so it's very applicable. We know that for metastatic disease, platinums have been in the backbone, whether cisplatin or carboplatin, for decades. For first-line therapy and immunotherapies available for patients who progressed on platinum therapy. And I believe in India, a lot of people use avelumab more than other drugs, but these are the 3 drugs that can be used: pembrolizumab, nivolumab, or avelumab. And antibody drug conjugates are the latest and the greatest drugs. And I know our colleagues in certain hospitals are also using these for patients who can afford it. It was first approved in the post-platinum, post-immunotherapy setting, enfortumab vedotin, which targets Nectin-4 and has an MMAE cytotoxic. And then there's also HER2-directed ADC approved for urothelial cancer based on very small cohort of 16 patients, trastuzumab deruxtecan. And then there's the FGFR inhibitor erdafitinib for patients whose tumors express FGFR. Enfortumab vedotin and pembrolizumab is the global frontline standard, replacing platinums. But of course, access and affordability is a huge issue. And there we need novel trials for more therapies. So let's talk about tissue-based biomarkers first. So what we have learned so far and thinking ahead, PD-L1 looked like a very promising biomarker early on when the immunotherapies were being developed. But we have learned that it has really not panned out to predict response to therapies. For example, in this first-line trial of gem-carbo versus pembrolizumab in patients with metastatic disease, as you can see, patients, even those who had high PD-L1 score of CPS 10 or higher, response rates with pembrolizumab were only 30%, and with gem-carbo were 46%. And overall, also, the response rates with pembrolizumab were 28% and gem-carbo were 42%. So really, it did not show any usefulness in this setting. Another study of atezolizumab versus platinum in the frontline setting, we saw that overall survival was not different in atezolizumab versus platinum, whether patients had no expression of PD-L1 or high expression of PD-L1. So we really have moved away from PD-L1. At this point, there is no role for testing for PD-L1 in the metastatic setting. In adjuvant setting, in the US, for example, after cystectomy, also there's no role for testing for PD-L1. It's the clinical factor that determines high risk. But in Europe, they do use PD-L1 because there was greater benefit in those patients just to save some costs. Tumor mutational burden is a more promising biomarker, in my opinion. As you can see, bladder cancer falls pretty high for tumor mutational burden, and Dr. Agarwal just talked about where it lands with prostate cancer, much lower. But we have actually done a big, large real-world study where we showed that tumor mutational burden is a predictive biomarker, which can help us decide whether to use immunotherapy or carboplatin gemcitabine in benefit in first-line metastatic urothelial cancer patients who can't get platinums. Now, this may not be relevant if you're using EV-Pembro, but this is, for patients who don't have access to EV-Pembro, who don't really want chemo. So this tool could help you decide. And we showed that if patients have high tumor mutational burden, which is defined as 10 mutations per megabyte cutoff, they can do well with just single-agent immunotherapy. You don't need to give them carboplatin. And we also looked at the phase 3 trials that looked at this. As you can see at the column C, the Danube trial showed benefit of TMB selection, even though overall the trial was negative. IMvigor showed that even though overall it was negative. And Keynote 361, we didn't have much data. Talking about FGFR in urothelial cancer, as the bladder cancer progresses, there's less and less expression in advanced setting, but early on, it's about 30 to 50% patients can express in non-muscle invasive setting, 30% in muscle invasive, 20% in de novo metastatic. And erdafitinib is an FGFR inhibitor, which has shown activity in metastatic urothelial cancer. In the real world, I would say its FGFR alterations are seen in less than 15% patients. And so I hardly have any patients on this drug right now. But we also have clinical trials with better drugs. Now, in a single-arm trial with erdafitinib, we saw good activity, 40% response rates, overall survival of 12 months. This drug is pretty toxic, not like any other tyrosine kinase inhibitors. The phase 3 study compared erdafitinib to chemotherapy of choice, which could be docetaxel or vinflunin, which is available only in Europe. These are patients who've had 1 to 2 lines of prior therapy. And this showed that if they were selected for FGFR, erdafitinib was superior to chemotherapy. Now, I don't think erdafitinib is available in India, but you can correct me if I'm wrong. But this is an option for patients who do express FGFR. HER2 is another promising target. Earlier trials with HER2 in urothelial cancer were negative when they tried to use Herceptin and other drugs, but these antibody drug conjugates like trastuzumab deruxtecan has shown activity in a pan-tumor trial. If you look at bladder cancer, very few patients, but it showed that in HER2 3+, it had activity even in HER2 2+. So in the US, it is approved across the board, and it's an option for us if patients express HER2 it has to be tested on IHC using the gastric cancer methodology. Again, very few patients will be actually able to get this, but this is an option. And I think, even though we have all these therapies, we are still offering everybody blanket treatment. We are not really selecting patients whether they'll benefit from immunotherapy or not. We're just offering all these expensive drugs, and we should work towards offering personalized treatment. Bladder cancer in general is a very heterogeneous disease. If you look at RNA sequencing, they can express, luminal type, or they can, which is FGFR upregulated. They can have basal squamous type, neuroendocrine type. And some work has shown that, you could target luminal type with FGFR inhibitor or basal squamous type with immunotherapy, but it's still not standard of care. This is all research work. Now, blood-based biomarkers are the latest biomarkers that we see a lot of promise with. For example, circulating tumor DNA. I know it's available in India, although expensive. We know that it is prognostic in muscle-invasive bladder cancer, whether patients get neoadjuvant chemotherapy or neoadjuvant immunotherapy, which is also single agent is not a standard, but it was shown that it's prognostic. If patients have positive ctDNA status after surgery, they do poorly. And in this large trial, which was adjuvant atezolizumab in high-risk bladder cancer, it was a negative trial. There was no improvement with atezolizumab for disease-free survival or overall survival. But when they looked at patients who were ctDNA positive versus negative, those who were positive derived overall survival and disease-free survival benefit with atezolizumab. So this is one of those negative trials, which is the most important trial to date for biomarker in bladder cancer. And that's because this trial led to this phase 3 trial, IMvigor011, where patients who got cystectomy with or without neoadjuvant platinum, and if in a 1-year period they ever converted to positive ctDNA, they were prospectively randomized to atezolizumab versus placebo. And this was based on the information from the negative trial. And the latest update is that this is a positive trial. It will be presented at our ESMO meeting next month. This trial showed that only patients who had ctDNA positive disease, they benefited from atezolizumab. And in this study, those were the patients who were treated, rest were just followed if they were ctDNA negative. So this is the first study showing predictive benefit of adjuvant testing of ctDNA. There's another trial ongoing, which is going through some changes, called Modern Trial. So that is pretty much all we have right now that we can play around with in bladder cancer. And in conclusion, PD-L1 is just a useless biomarker to guide treatment, should not be used to decide whether immunotherapy should be offered or not. But if in the adjuvant setting, you're trying to really use it and spare patients some cost, you could use it. Tumor mutational burden, sorry for the typo, it is more robust, but it has never been validated in prospective trials. ctDNA is, I think, the most promising biomarker. We have already seen its utility in the IMvigor011 trial. And antibody drug conjugates hold a lot of promise. There's a lot of targets, but we are not using any target testing for informing us whether to use, for example, enfortumab vedotin or not. But for HER2, we are. An emerging role of urinary biomarkers and AI-based approaches is yet to be seen. That is my last slide. Would welcome any questions.
Thanks so much, ma'am. It was a very comprehensive summary. Would you recommend any platform for urinary biomarkers?
I think Predicin is a good one that we know here, but there's a lot of companies doing it. I don't know in India, do you have companies, which companies are into it? But I think it's a more useful biomarker if bladder is intact, that way you're not depending on the blood biomarker.
Right. We don't have validated platforms. I mean, I don't know if I can recommend a platform, but everybody definitely talks about using urine.
We don't have
or
validated
acetylflow.
either. It's all research right now.
Right.
Well,
So, ma'am, while you,
Dr.
yes,
Niti, I just like your permission to leave for my next meeting. But what a great talk, fantastic talk by Dr. Gupta, as always.
Thank you, Neeraj.
Thank you.
Thanks. Have a great day.
Yeah. Bye-bye.
Thanks so much, Dr. Neeraj.
Yeah.
We'll keep bothering you.
It's good
So,
you're doing
Dr.
this
Shiv-
forum there. Yeah.
Dr. Shilpa, what we'll do is we'll quickly move to the case presentation which
Yeah,
we have,
let's
so
do
that
that,
I
yeah.
mean,
That's why I kept that
so
short.
yes, Dr. NRN Sharma, he is a consultant medical oncologist at Max Delhi. Over to you, sir.
Oh, nice, nice. You know, I'm going to Max next week. You'll be there?
Oh,
Yeah, I'll be there.
Yeah,
They had
yeah.
opportunity.
Yeah. I don't know if we met last year or not. I think we met last year, right?
No, I was not there last year. I think we'll be meeting you this year.
Okay. Yeah. I'm very excited. So I'll see you on the 4th.
Perfect. So, because of the paucity of time, I will come straight to the presentation. There are
Yeah, please.
interesting cases which I'll be presenting. I will come to the first case first. So, 80-year-old gentleman from New Delhi in 2023, he was diagnosed with having metastatic urothelial carcinoma, and the metastatic sites were non-regional lymph node. The tissue NGS was done later on. It's the report which we have mentioned here, but it was done from the progressive site later on. So initially, we started this patient on gemcitabine and carboplatin Q3 weekly in attenuated doses because of his geriatric age. Whole body PET scan after 5 cycles was showing a stable disease. And based on the Javelin Bladder 100 trial, we have started this patient as the patient was having a stable disease on avelumab maintenance. To our utter surprise, after 4 cycles of avelumab maintenance, when we did the first response assessment scan, it was suggestive of a progressive disease. There were new lesions, especially the abdominal wall deposits were there. We did a biopsy to confirm, and the left abdominal wall biopsy was suggestive of that it's a metastatic, poorly differentiated urothelial carcinoma with squamous differentiation. So the question which is standing on table is that
Was the original biopsy also squamous differentiation?
Yes, it was there. And it was
okay. So it was the same then.
So
it was not pure
yeah.
squamous. It's
Correct.
squamous differentiation. Yeah. Okay.
Differentiation. Right.
Yeah.
So the question which is standing on the table is that what modality of testing you would recommend when the disease outsmarts the treatment? We should go for a tissue NGS, liquid NGS, or should we do both of them together? Right.
Yeah. You know, I would answer this question based on where you are practicing. You know, I don't think the kitchen sink approach is feasible if somebody has to pay out of pocket, So if I were practicing in India and patient, these tests are expensive, right? So I would say that tissue is fine if that is cheaper. It's not like liquid is adding anything new. It's just, you see the dynamics of it now, but it's very, very rare that the liquid will really show you something that tissue has not shown, unless the tissue is like 10 years old, right? But in your case, it was a de novo metastatic patient. So I would say tissue is fine.
Perfect. So whether in your practice, you're doing the tissue-based NGS upfront when the disease is diagnosed, or you are doing it when there's a progression on the standard lines of treatment?
Actually, we've started doing it as soon as patient has locally advanced or metastatic disease. Because then, it does take time. And then if patient is progressing rapidly, then we have to wait and all that. So it's a good idea to just do it when the tissue is not that old.
Okay, right. So in this case, as you correctly mentioned, so we have gone for a tissue-based NGS and we have sent it to US only in foundational NGS. And this is what the report unfolded. And meanwhile, because it takes nearly 3 weeks for the reports to unfold, we have given palliative RT to the sites where the disease was active.
Right.
So as you can see clearly, the tissue-based NGS from the progressive site biopsy was suggestive of a KRAS A95G mutation. Along with that, the patient was having a CKTN2A, BP16, INK4A, and D84N mutation, along with that P14ARF98Q mutation. The PD-1 CPS was suggestive of 80%, and patient was also having a KMT2D, that is MLL2, and TP53 mutation also. So meanwhile, in our tumor board decision, that we decided to send a TROP2 IHC, although we know that the approval upfront when it was there, it was irrespective of TROP2. But even then, the patient also insisted that it's better to check the marker and then take action accordingly. So
and also, it's ubiquitously expressed, and the drug has been withdrawn because the phase 3 trial is negative anyway.
Absolutely right.
Okay,
so that time, this is an old patient, obviously. So that time the trial was active and it got a accelerated approval. So the TROP2 IHC was positive in this case, as you can see clearly, it's done in our lab. So as we know that you correctly mentioned, it was withdrawn, but that time, so antibody drug conjugate, it is sacituzumab govitecan, which was approved by US FDA, consisting of TROP2 directed monoclonal antibody directed against drug SN 38 topoisomerase inhibitor by hydrolase linker CN2A, and the trial was of just 45 patients. It was IMU 13201 trial, and the objective response rate which was published was 31%. The 14 out of 45 patients responded to this. There was a phase 2 Trophy U01 trial of SG demonstrated an objective response rate of 27.4%, although the side effects were diarrhea, nausea, fatigue, and alopecia by and large. So SE got a approval. It was a accelerated approval for locally advanced metastatic urothelial carcinoma, post platinum chemotherapy, and post progressive disease or PD-L1 inhibitors. So the dose which was recommended was 10 mg per kg weight, day 1, day 8, Q3 weekly. This was the body of literature when this patient presented, right? So we started this patient on SG at the point of time in 2020-24, and we used 50% of the doses. Why? Because of his elderly age group and the performance status. So after 3 cycles, there was a complete metabolic response, and we continued this beyond that, and total 5 cycles of the chemotherapy patient received, and he achieved CMR again in the one more scan which was done. So total 6 cycles were given. Patient was like eating well, sleeping well, moving around, as an excellent performance status, although alopecia was a troubling event to him. So the question
is the CMR complete response?
Yeah, there was no disease in the PET scan.
Okay.
So radiologically, it was a CMR, right? Clinically, also patient improved dramatically with a 50% dose of SG in a period of time. So the question standing on table is, what are the next testing should be done? Because already we did NGS, and what are the treatment options if the disease progresses on the current ADC regime, right?
I think in this case, you could give a treatment break too, and could monitor with ctDNA, so you can spare the toxicities, because this drug is pretty toxic, diarrhea and all that. So if, let's say, next treatment options, you could test for her too, based on the stomach testing, not the breast one, right? And then if that is positive, you could try TDXD if it is available. I don't know if it is, but if the patient can afford, And then there is, in this case, immunotherapy already failed the patient one time. I would not re-challenge with any other immunotherapy. And so what I would do, if patient is, derived a complete response to SG, give a break right now, monitor with ctDNA every 3 months or so, and scans, whatever. Then if patient recurs, give SG again. So you can give like break from SG, use it in an intermittent way. In the meantime, test for FGFR and HER2. But FGFR you already tested, so that's gone. So HER2 IHC.
Perfect. So as you correctly mentioned, I did the same thing. I have given a treatment holiday for this patient, and to my utter surprise, patient is off SG for past 1 year now, and the latest scan also is clean, is in
Very good.
PS1. Right? So the question which is standing is that the drug have worked amazingly well, although the approval is withdrawn now.
Right.
People are aware of that. So what about, can we start a ADC again? Like the patient, suppose progresses in next 1 year or so, this patient has done amazingly well.
Then give SG again, because patient.
Right.
I would not give EV if you. Oh, no, you never
HER2
gave
is negative.
EV to.
HER2 is 0. Suppose we did a HER2 IHC. Suppose it comes out to be IHC 0.
So
negative.
You have not given EV yet, right?
Right.
Yeah. So if patient recurs again, since it has been over a year and did so well with SG, just give SG. And if that doesn't work or progresses, then EV is also an option. Absolutely.
Okay.
You should give EV. Or, depends on what's cheaper. But, you already know a drug that worked for this patient with just 3 doses. Why not just give that?
Right. So
Dr. Sharma, can I ask a question, Dr. Sharma?
Yeah,
where was the disease upfront? I mean, you said it was advanced disease.
Lymph node, right? You said
non-regional lymph nodes, right?
Non-regional lymph nodes were like in the para-aortic region or something.
Yeah, para-aortic, and there are some nodes in the mediastinum also. So above and below diaphragm nodes were there.
So that's, and then recurrence in abdominal wall.
Absolutely.
I have to really go in just a minute or so. I'm sorry. I'm actually out of country doing a meeting, but I really wanted to do this. But yeah, anything else on this patient?
Yeah, that's, I got your point. Just 1 minute I will take. I'll present one more case, which is also interesting. I think Dr. Shilpi, I will request you just for 1 minute if you give me.
Yeah, sure.
71-year-old gentleman from Bangladesh is an international patient with the comorbidities of diabetes, CKD, and post-silicone disease stenting. He was evaluated elsewhere in other hospital in Bangalore. May 2019, he was diagnosed with having early stage prostatic adenocarcinoma and underwent a local therapy for that. That is RARP with bilateral extended pelvic lymph node dissection in Manipal Hospital, Bangalore. Later, TURBT was done in Dhaka and bilateral PCN was inserted, and there was followed by a antegrade digit stenting in 2020. 2021, he came to Medanta, where I was working earlier, and I diagnosed him with the second primary, that he's having a metastatic urothelial carcinoma. It was stage 4 because of the metastatic site, which is bone, hepatic, that liver, and non-regional lymph node. We started this patient on gemcitabine and carboplatin along with the bone-directed treatment. The patient progressed after 6 cycles, and we discussed in tumor board to go ahead with the second line pembrolizumab Q3 weekly, as we know that pembrolizumab single agent is approved in second line when the disease outcomes treatment. Patient did amazingly well. For 10 cycles, he was on pembrolizumab in second line for urothelial carcinoma. And in May 2022, the disease again progressed. We confirmed it by a perirectal lymph node FNAC and cell work, which was suggestive of a metastatic carcinoma from urothelial origin only. So it was deemed oligoprogressive disease, and we are given a palliative RT to these pelvic lymph nodes and mesorectal lymph nodes by June 2022. Meanwhile, after radiation, because it was oligoprogressive disease, elsewhere patient was having a oncologically quiescent disease, we have continued pembrolizumab and denosumab. Patient took 14 cycles of pembrolizumab, and last 4 were given in Dhaka because he cannot stay in India for longer duration. Again, in September 2022, the disease again progressed, and now there was new retrocaval pre-aortic, and there was a lymph nodes and significant increase in the left lung tiny nodule which was there, and patient was symptomatic for respiratory symptoms. So we thought that this disease is progressing on the treatment, and this is a nuclear scan, which was PET scan, which was done, and it's showing that there was irregular nodule in the lower lobe of the left lung, along with the nodes which I mentioned. So,
but you said that nodule was not new; it just increased in size, which is expected on immunotherapy. So,
absolutely right.
I would not call that a progression.
It was not sampleable upfront; it was too tiny to sample. Later on, there was an increase in size of that lung nodule.
But there was nothing else new, though, right? So yeah, that means pembro could still be continued, but with the radiation. Okay.
So the case was discussed in the other hospital, Medanta, and it was planned to treat the lung lesion, the non-regional lymph node, with a short course RT and followed by systemic treatment. Meanwhile, the patient came to Max Hospital, Saket, New Delhi. We did a biopsy from the left lung nodule, and to our utter surprise, it was NSCLC adenocarcinoma, which was the third primary. We confirmed it by IC. It was TT1 positive, and there was a pleural effusion also, which was mild, and we have checked that was positive for malignancy. So by and large, this patient is a case of metachronous stable malignancy. 2020, early stage prostatic cancer in Manipal Hospital, Bangalore. 2021, it was urothelial carcinoma in Medanta, Gurgaon. And 2022, it was an NSCLC adenocarcinoma in Max Hospital, Saket, New Delhi.
Right.
The performance status of the patient is well preserved. So we discussed in our tumor board. We started with the pembrolizumab and carboplatin as the performance status was good enough. And meanwhile, we decided to go ahead with
PD-L1 positive.
Yeah, that's why I'm coming to that. So we did a NGS, and along with that, PD-L1 also we did. Meanwhile, 1 cycle of pembrolizumab and carboplatin was given, and this was the NGS report. NGS report have unfolded that patient is having a uncommon EGFR L861Q mutation with a tumor mutation burden of 7 mutations per megabase, and MSI was stable.
I just have to go, so maybe we can just, I see that EGFR was positive, okay.
PD-L1 was 0%. Right.
Okay.
Right.
That's
and
why
EGFR VAF was 35.2%, as you can see clearly. So it was
you started the word. Okay.
Right. So we started this patient osimertinib. So question which is standing on table right now is patient was having an oncologically quiescent disease on pembrolizumab, right? The lung was a new primary. So can we continue osimertinib along with pembrolizumab? We know that.
Yes. That I don't know. I would not do that. I would stop pembro because total duration has to be only 2 years anyway for bladder, and if the patient can afford it, give 2 years. Otherwise, if there's a CR from complete response from bladder, you can stop. I stop a lot of patients early on if they're maintaining complete response, and just treat lung with this or SBRT in addition to that.
Right. So
I'll have to take my
only point is like, shouldn't we continue pembrolizumab because it was like urothelial cancer was quiescent on pembrolizumab? This is a new primary which we picked up.
No, but what I'm saying is that, you can, maximum duration is 2 years. But, for patients where cost is a criteria, like even here where cost is not a criteria, if patients maintain complete response, I can stop immunotherapy at 1 year because their immune system is already engaged. You don't need to keep giving it. But that's something you can play with. I do have to leave, but this is very, very interesting case. Thank you so much. I'm sorry for the rush. It's just like we have a gap, but you can always email me and I'm happy to share some thoughts.
Perfect.
But this is really great. Thank you.
Right.
Okay.
So the fight is at
Great.
molecular level. Thank you. Thank you very much.
Thank you very much. Thank you
Thanks
so
so
much
much,
for
Dr.
the
Shilpa.
invitation, Dr. Niti. Bye-bye. Take care.
Bye.
Thank you.
Bye,
Thank you,
ma'am.
Thank you.
So, Dr. Sharma, you want to say something about your case?
Right. Just want to tell Dr. Niti that direction is so much important than speed. Majority of us are going nowhere fast. Right. So this was an interesting case of triple malignancy, metachronously presented, and the patient was so happy that we have picked up. But on the other hand, he was unhappy because he told me that I've gone to Manipal Hospital, Bangalore. Manipal Hospital, Bangalore, given me prostate cancer. I came to Medanta. Medanta, you only diagnosed that you're having a urothelial cancer. Now you came to Max Saket, you have given me third malignancy. Please don't switch the hospital, otherwise I will get the fourth malignancy and I will die.
That is extremely.
I want to share.
That's very funny. Yes.
Right.
Yeah.
So that's why I told that direction is so much more important than speed, and majority of us are going nowhere fast. And in advanced malignancy, the dictum is that cure sometimes, treat often, and comfort always. Right. So you never know that when patient will knock the door of your OPD and give you a surprise. Right. So ultimate aim is that it's not the drugs
Yes.
or the combination of drugs which conquers cancers. It's actually the correct sequencing of the treatment modalities, the patient's willingness to fight against the disease, and the knowledge of the treating doctors, which ultimately conquers cancer. This is what by and large we have learned over a period of time.
Yes. Thanks so much. It was absolutely wonderful. But I would have tried to give a combination of pembro and osimertinib, knowing the problems of giving it together, especially ILD and probably, IO-related pneumonitis. I would avoid giving it together. And also one thoughts, I think we'll take a quick input from Dr. Nisarg Joshi, that when you're doing bladder cancer progression, if you want to do an NGS, his thoughts on tissue versus liquid, I would want to do tissue, mostly to establish fusions, which will be difficult to see in blood. So what are your thoughts, Dr. Joshi? Mute.
Yeah.
So, ma'am, I think tissue would be a better platform because it also evaluates RNA, and in bladder, fusions are very important biomarkers. So, if tissue is available, it should be chosen. Ideal is liquid plus tissue, but in case if you have to choose one, then definitely tissue should be preferred in this case.
Right.
Perfect.
So a wonderful, enlightening session. I think all of us thoroughly enjoyed this session, and we should have more sessions like this. Thanks so much, Dr. Dabard, and thanks so much, Dr. Sharma, Dr. Joshi, and of course, our speakers.
Thank you. Thank you very much, Dr. Niti and entire team. Right. Thank you.
Thank you, ma'am. Thank you, everyone.
So we'll end the session today. Good night.
Good night.
Thanks so much.
Thank you, everyone. Good night.